Well, it's a real pleasure to be here today. Listening to the previous speakers made me realize that, we have an election in the United States going on right now. Some of you may have heard of this. And I get chest pain every time I hear one of the candidates speak. So I wonder if that's a reason to have a catheterization. Actually, I get chest pain when either one of them speaks, but particularly Trump. So I'm delighted to be in your country and in this city. I'm delighted to have learned more about the Brazilian healthcare system and the hospitalist model here. And I thought I'd spend a few minutes talking with you about the hospitalist model in the United States and how it first got started. So first I'll say that I grew up in this part of the United States down here, Tennessee. And for the last 16 years, I've lived over here. And I have learned that the thing people here most want to know about me is where my accent is from. I will have the occasion of treating a patient, and perhaps it's a very serious illness, and I say, I think you may die from this, and ask the patient and the family if they have any questions for me now. And even facing this very serious issue, most often their first question for me is, where's your accent from? It's that degree of fascination. And accent of people from this part of the country is generally someone who speaks more slowly, which I hope is of benefit to the translator, and also an accent that does not make one sound particularly smart. So it's sort of associated with people who are not so smart. Hopefully you will not detect that. In preparing for this talk, I realized this may be one of the first times I'm speaking in front of an audience who may not pick up on my accent. So I feel that much more confident speaking today. So let me just start with the basics of hospitalists. I presume most of you know this. First, the Society of Hospital Medicine is the professional society for hospitalists in the United States. I actually started that organization with another hospitalist in 1997. And we came up with this definition. Now, I'm not so smart because I now realize I decided to see if I could translate that, and I now realize I can't read it for you. So I think that you won't have trouble with it. So basically, a doctor whose focus is the care of hospitalized patients. That defines a hospitalist. So the hospitalist movement has grown rapidly in the United States, and I think we can say with confidence it's the fastest growing specialty in the history of healthcare in the United States. When measured in terms of numbers of practitioners, no specialty has grown more quickly. So this is over just a few years. I became a hospitalist in 1988, so many years before this, and I couldn't find anybody else who did the same thing, and this bothered me. I thought, well, this is unusual. I'm doing something that perhaps is not very professional or not very good, and in fact, in the first few years, I thought about giving it up and doing something more common, practicing in a more traditional manner. But I didn't give it up. I started instead trying to locate other doctors practicing the same way. And I really enjoyed the fact that I would find some every now and then. Not often, way back in the 80s and early 90s, but as time passed, more and more often I would find someone else who had started practicing as a hospitalist also. And we always enjoyed meeting one another and exchanging ideas. How hard do you work? How hard do you work? How much do you make? How much do you make? And so forth. So we learned a lot from each other, and this led to my interest in starting the Society of Hospital Medicine. So we're growing rapidly, and just as a frame of reference, we're now well over 50,000 hospitalists in the U.S. That's more than the number of most medical specialties. So there are not 50,000 cardiologists or intensive care doctors or infectious disease. It's one of the larger fields in U.S. healthcare when measured in numbers of practitioners. So why did this happen in the U.S.? Why did the hospitalist movement catch on in the U.S.? And there's many reasons, and I want to walk through some of them now. If you ask a lot of healthcare professionals in the U.S. why hospitalists got started, why this happened in the U.S., the most common single answer you'll get is people will say, well, it was something promoted by health insurance or by hospital executives. People that pay for health care and wanted to save money promoted the hospitalist movement. So that's true to a degree, but I think very, very misleading. There are many other reasons independent of financial concerns that led to the growth of hospitalists in the U.S. A big one is how primary care physicians were spending their time over years. So I'm speaking of internal medicine and family physicians who traditionally in the U.S. saw patients in the office and in the hospital. And if you go back to the 1960s, the average primary care doctor spent about 40% of his or her time in the office and in the hospital, about 40% in the hospital and about 60% in the office. But the portion of time spent in the hospital declined, and by the mid-90s, it was very small. If you instead speak of this in numbers of patients, the average primary care doctor would have had 10 to 20 patients in the hospital every day in the 1960s. By the 1990s, the average was 2 or 3 patients per day in the hospital. Some days, 0. So it became harder to justify a doctor going to the hospital and spending some time and then going usually to a distant location, maybe 10 minutes away, to an office. Why bother to go to the hospital if there's only 2 patients to see? So that's one of the reasons primary care physicians said, I don't want to do that anymore. I think I'd like to stop seeing hospital patients and focus my practice on the office. So in my opinion, one of the biggest reasons hospitals appeared in the U.S. and grew rapidly is that it's exactly what primary care physicians wanted. They were leaving the hospital, leaving a vacuum that hospitalists then filled. So the desire of primary care physicians is a big reason for the growth of hospitalists, even though you may be aware that there even today are primary care physicians in the U.S. who say that the whole hospitalist idea is a bad one, it's a terrible thing that's happened in medicine. But that's a small number. They're very vocal, but there are not many that have that opinion. Most primary care physicians, in fact, decided to leave the hospital, and we, the hospitalists, filled that space. Another way to look at this is thinking about the skills and knowledge required to be a good doctor in the office versus the hospital. Back in the 1960s, I have made this up, but I think most would agree this is generally true. In the 1960s, if you look at the skills and knowledge base required to be good in an outpatient setting versus what's required to be good in an inpatient setting, there's a great deal of overlap. It's almost the same skills and knowledge base in both settings. But if you look at today, in my view, 2 things have happened. Each of these bubbles or circles is now larger. There is more knowledge one needs to know in both settings, and the amount of overlap is much smaller. So I think today it's harder for a doctor to be expert in both settings. In the outpatient setting, one today needs expertise in vaccination schedules, lipid management, cancer screening, all kinds of things that don't come up much in the hospital. In the inpatient setting, one needs expertise in sepsis protocols, antibiotic stewardship, things like that, that are either not an issue in the outpatient setting or have very different applications. So I think that the growth of medical knowledge makes it harder for any single person to remain expert in both places. Another way to think of this is that we in the United States felt like there was a need, or some felt like there was a need to create what we refer to as a focused factory. That is, you think of the hospital as a factory. We need people who think only about how to make that the best factory it can be. We need focus. And if you have a lot of doctors spending time both in outpatient and inpatient, they are less focused on any one site. So there can be value in having a set of doctors very focused on the hospital, as well as a different set of doctors very focused on the outpatient setting. That can, in theory, improve the care delivered in both settings. Another factor that pushed the development of hospitalists is lifestyle choices. So the work of a primary care physician in the United States can be pretty hard. Across all medical specialties, it's among those specialties that have the longest hours, the most on-call work, the traditional primary care model. So doctors were wearing out. It was hard for doctors to keep doing that. And now that I'm an older doctor, I can say it too. The young ones don't want to work so hard. So the young ones coming out, when I did, kind of made a different choice and said, I don't want to do all of that anymore. I think I'd rather narrow my practice to one setting and perhaps have a better lifestyle. And hospital medicine offers that. So hospitals also were supporters of the hospitalist movement, primarily because it lowered costs. So that was one of the first things that people who studied the effect of hospitalists realized. Many studies early on came out showing, wow, when you have hospitalists come to your hospital, the cost for each patient goes down. And at least the way things are arranged in the United States, the hospital got to keep the difference. So that was, it made the hospital more profitable. Hospitalists improved throughput, that is, moved patients through the system more quickly, lowering length of stay, reducing delays, and so forth. The presence of hospitalists made it easier for other places to refer patients to the hospital. The reasons for that would take a while to explain, but relate to the way U.S. healthcare was configured and has been configured historically. The arrival of hospitalists makes referrals into a hospital go more smoothly in many cases. And there's other advantages, which for the sake of time, I'm going to, I won't discuss each one of them. But hospitals have embraced hospitalists in a very, very big way. This is some data to support what I just said, that the arrival of hospitalists resulted in lower costs. So this study was by Bob Wachter, who's a friend and the person who coined the word hospitalist, as many of you may know. And this is from a long time ago, published in 1998. But I show it because this and studies like it were one of the early ones that propelled growth of the hospitalist movement. They did a study looking at two outcomes. One was length of stay, the other cost per case, and this is what the hospital spends to take care of the patient. The study was configured in two parts. The red portion of each graph is before the arrival of hospitalists. So this is every patient in the hospital had a length of stay from about 5.2 days over time, over these years. That length of stay declined from 5.2 to 5 days. And the cost per case came down from $8,500 to $8,078. So all that happened without hospitalists. Length of stay and costs were coming down even without hospitalists. But when this hospital had hospitalists in place, they then divided about half their patients so that they were cared for by hospitalists, and that's the green line. And the other patients were cared for by non-hospitalists, the traditional model of care. That's the yellow line. And what this shows is that when hospitalists arrived, length of stay dropped much more rapidly than with the non-hospitalists, and the same for costs. So this, the difference in cost here is about $700 per patient. And if you multiply that by hundreds of patients, that becomes a meaningful amount of money in a hurry. So this was a often quoted study, and one that you may, or perhaps you've done this already. Somebody in Brazil has done a study like this. It would be worth assessing this to see if you're experiencing the same change. So there's other variables that other studies examined. Things like the median length of stay was for non-hospitalists, was higher than for hospitalists. Costs, again, lower by, in this case, $1,000 compared to non-hospitalists. How often the hospitalist requested other doctors to help care for the patient as a consultant was a little bit less with hospitalists. And readmissions was lower. Now, this was also a long time ago, 2002. So these studies and others like them supported the idea that hospitalists were valuable. So were valuable for hospitals. So what about other doctors? Some have said that the arrival of hospitalists are a bad thing, some doctors. But as I mentioned before, not many. Most doctors say that the arrival of hospitalists has been a good thing. For primary care physicians, it allows them to focus all of their time and attention on their office. Historically in the United States, and I would guess maybe here as well, a doctor who worked in both the office and the hospital would have appointments in the office today, for example, and maybe is scheduled to see somebody at 11 a.m. today, but was delayed in the hospital because of a sick patient. So the patient who's coming to the office, who's had this appointment at 11 a.m. and been planning on this for 3 months, finally I'm going to get my headache checked or my chest pain or whatever in this office appointment. The patient arrives only to be told by the receptionist in the office, sorry, the doctor is late in the hospital because of a very sick patient. Do you want to wait several hours or do you want to reschedule? So that was historically the model in the U.S., and patients just put up with it. I'm sure they never liked it, but they didn't complain much. They didn't feel like there was any other choice. Well, by the 90s, they had begun to see it differently. They said, I don't want to reschedule. My appointment's at 11. Go get the doctor. So the arrival of hospitalists made it more possible for the office doctor to be available continuously and at least not be interrupted because of problems in the hospital. By focusing their care exclusively on outpatient setting, those doctors were able to improve the quality of care in the outpatient setting. They realized an improved lifestyle. Those doctors focusing only on office practice generally don't have to be on call at night. They don't have to come to the hospital at night for sure. They may have to answer phone calls from patients at night and discuss things by phone, but they never have to get out of bed to go see a patient at night. So they liked that a great deal. And for some doctors who focused their practice entirely on the office and gave up the hospital, they actually saw a rise in their income because they could be more productive overall by spending all their time in one setting instead of dividing their time across two settings. The doctors other than primary care physicians, so surgeons, emergency physicians, intensive care doctors, others, were pleased to have hospitalists because of the hospitalist's continuous availability in the hospital. The other doctors liked that a great deal. So I've gone through a list of stakeholders and why they benefit from having hospitalists. I've talked about the hospitals, about hospitalists themselves, about other doctors, But most importantly, what about patients? We shouldn't do this if it's not potentially good for patients. So most research data tends toward benefits for patients of the hospitalist model. It's a little bit mixed. It's not all convincing that the hospitalist model has done great things for patients, but it certainly tilts in that direction. As I've already mentioned a few times, patients benefit by having greater access to a physician dedicated to care at either site. The arrival of hospitalists in some settings meant patients less often presented to an emergency room or urgent care center because they could now have greater access to their regular doctor in the office for a scheduled appointment. So there were many secondary effects and benefits of hospitalists. Hospitalists benefit patients not only by having more experience in, for example, the pathophysiology of inpatient disease, but more experience in managing the hospital system. Things like memorizing phone numbers of the radiology department, knowing by first name the ultrasound technician and the EKG technician and the nurse on the third floor. If I'm in the hospital all day, I know those people much better. I think that translates into some benefit for the patients. I can help get the system moving more effectively for patients than a doctor who is there only occasionally. And if you ask patients, and people did this some years ago, if you ask patients satisfaction of seeing the doctor they know from the office during a hospital stay, or seeing a hospitalist who is a stranger for them, they report levels of satisfaction that are about the same. So patients are reporting, yes, I find the hospitalist system satisfactory. So there are some other studies about quality outcomes. These are more difficult to do, but in general, the studies point toward some potential benefit for healthcare outcomes when hospitalists arrive. This study showed maybe some benefit in mortality when hospitalists are compared to non-hospitalists. This one showed a somewhat more convincing benefit. There are other studies, and again, they're a little bit mixed, but most tilt toward benefits of the hospitalist system. There is sort of a more recent study. I think it's 2007. So more recent studies, which are probably more robust and more representative of reality, suggest that hospitalists do have a shorter length of stay, probably not as dramatic as earlier studies showed, but somewhat shorter length of stay without any adverse effect on the rate of death or readmission. The mortality rate and readmission rate might be better with hospitalists, but it's not dramatically better in this more recent study. And then costs in the hospital are lower, but more recent studies tend to show costs that are not as dramatically improved when compared to earlier studies. So why are doctors choosing to practice as hospitalists? I think most in the room can answer that question, at least from the Brazilian perspective. In the U.S., doctors say, well, I think I was best prepared in my training to care for hospital patients. In my training, I had this much time in outpatient care and this much time in hospital care. So when I finished my training, I thought it made much more sense for me to practice inpatient medicine. I also liked the fact that I wouldn't have an outpatient clinic. I didn't want to have the responsibility, and for me, the exposure to outpatient clinic I had in my training made me think it was not such a good place to work. I think I may have drawn the wrong conclusion. It may be a very good place to work, but many, when they finish their training in the States, prefer to stay in the hospital and not the office setting. So there's a number of reasons that, again, I will not go through in detail, but many doctors are choosing to practice as hospitalists, and that's why the number has grown so quickly, as I showed you earlier. Let me conclude by talking about one issue. I'd like to talk all day about what is the life of a hospitalist like in the U.S. And I don't know how that might sound to some of you who have been to the U.S., you talk to people there about what it's like to be a hospitalist or what you read. And I also don't know that your experience will be the same. It may be very different in Brazil to work as a hospitalist. Your satisfaction with that work, the stress, it may be entirely different. But in the U.S., hospitalists are finding that work stressful. So there's a study of burnout of U.S. physicians, and this study did not separately address hospitalists. There is no hospitalist listed here. But the specialties most at risk for burnout were emergency medicine, general internal medicine, so that's primary care practice, neurology, and family medicine. Very high rates of burnout, very concerning. If you look at that, 60% for emergency medicine. Most emergency medicine physicians have some manifestations of burnout. That's very concerning. So what about hospitalists? We don't know for sure. There have been some studies of hospitalists in particular, and they tend to suggest we're more likely to be up here than down here. So this is a worrisome thing to me. There's many reasons that hospitalists have burnout. One is the choices made around the work schedule of a hospitalist. I won't describe that in detail, but in my view, that actually promotes burnout. Another issue in the States is hospitalists often will say they feel a little bit disrespected by other doctors. They don't feel like other doctors see them as equals. I think to some degree that problem is the fault of hospitalists themselves, partly. Their behavior, the way they dress and act is not, in some cases, as professional as others. So I think we hospitalists have ourselves to blame for some of the problem of respect. But there are many hospitals where this is simply not a problem. In my hospital, it's not a problem. The other doctors, we are peers and equals with the other doctors. But in some hospitals that I visit and work with around the country, it's not that way. The hospitalists are not as respected, and that causes distress for them and reduces their satisfaction with their work. So these are some earlier studies about burnout, and I think I'll skip the data. So burnout is a concern for our field and something we should watch. So that's a concerning thing. And I think a very fascinating thing happening in the U.S., and I'd love to know if it's happening here, the practice model of a doctor focusing all of their work on the hospital, that is the hospitalist model of practice, is being adopted by doctors in many, many other specialties. If you had asked me 10 years ago whether that would happen, I would have said, no way, that's never going to happen. But in fact, it is happening in a big way in some fields. So in obstetrics, there are doctors who work only in a hospital, have no outpatient obstetric practice at all. And because all of their work is focused around delivery, they don't do any prenatal care. They just do delivery. Other doctors have done the prenatal care. We call them laborists, which in the U.S. sounds very funny. Labor is our term for the process of delivery. So general surgeons are adopting the hospitalist model. There are general surgeons who practice only in a hospital. There's maybe 300 or 400 in the whole U.S., so it's not really big, but it's growing. There are many psychiatrists who see only hospital patients. Neurologists, this is a big field. There is a Society of Neurology Hospitalists in the United States. So this is a growing field of neurologists who have no outpatient practice. And orthopedics. There are some orthopedic surgeons who have only hospital practice. They often do a lot of trauma surgery. So in very large hospitals that have large volume of trauma, you might find orthopedic hospitalists. So I think this, for me right now in 2016, I find this the most fun and entertaining thing to engage with and pay attention to in the U.S. So that's where I wanted to stop. There's a million more things I could discuss about the U.S. model, but I'd be happy to take questions and hear from you about how your experience is different or other things you'd like me to comment on. And if there are no questions, I will conclude with the entire Portuguese vocabulary that I know, and that's obrigado. So.
Hi. So, you mentioned that a small, though loud, group of people who do not like hospitalists. What are they saying effectively?
Well, they mostly talk about disruption and continuity of care, and that, you know, maybe a patient got to know a doctor in the office for 10 years and really likes that doctor. I have a doctor. I have not been hospitalized since I was a child, but I have a doctor I've been seeing the last 15 years, and I like him very much. He's brilliant, and I know that if I go to the hospital, he's not going to be there, and I'm not happy about that. I would like to see him in the hospital, but I realize there's trade-offs. One reason he's good in the office is because that's what he does all the time, and if he came over to the hospital to see me, he would not be as smart in the hospital as he is in the office. So mostly they talk about what it means for patients, and that it's unfortunate that patients have to get a different doctor in the hospital. I agree with them. It's true. It is unfortunate. That's an unfortunate side effect of the hospitalist model. I think, though, that we have to be practical. The benefits outweigh those costs. Continuing to insist that things should remain the way they were previously isn't practical anymore, in my opinion. A funny story, though, I'll tell you about. It's most often very senior doctors in the later portion of their career that are most critical of the hospitalist model. So part of my work is with hospitalist groups all over the U.S. So I travel there and I'll spend several days. I'm not treating patients, but I'm helping them with the way they organize their practice, their schedule, their staffing, all these kinds of things. So I've been doing that for a long time. And when I go to these other hospitals, I will sometimes encounter these, you know, gray-haired senior physicians who are great doctors, and we should listen to what they have to say. But often they will say, "This is terrible. This hospitalist idea is terrible. It's ruining medicine." And, you know, it's very intimidating for me, and okay, you know, sorry. And so then I ask, I used to hear this a lot. It doesn't happen much anymore, but 10 or 15 years ago, it was very common. And then I would talk to that people at a hospital a year later, or talk to that same doctor. I'd see that doctor at a conference. So how's it going? What are your thoughts about the hospitalist model now? Do you still see it the same way? "Oh, John, it's very interesting you asked me that," this senior doctor would say. "You know, about a year ago, I decided, you know, my wife and I had tickets to the theater, and I was on call, and my patient needed to be admitted to the hospital. I wanted to go to the theater, so I asked the hospitalist to admit my patient that Saturday night. And then it went okay. The patient was happy. The patient was well cared for. So about 2 weeks later on a Saturday night, I did it again, and it was nice, and I liked it. And I began doing it more. And before long, I was doing it every day, all the time. And it sounds just like someone being addicted to cocaine or something. I did it on weekends. It was fun. Now I do it all the time and can't stop." But this is actually a very common story, that the most vocal critics of the hospitalist model became supporters of it themselves. Many, though, were not big enough they didn't have the character to admit that maybe they could see this differently. Many would say, "No, I began referring. Yes, I refer all my patients to hospitals, but I still think it's a terrible idea. Managed care or the insurance companies gave me no choice," and they stay angry about it. But in fact, they had a choice. Everyone had a choice, and And they just don't want to admit they wanted to refer, and it just hurts them to admit they were willing to make that change. So anyway.
Talk about money.
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 We can all use more. So
How about how is the remuneration? How
for
do
hospitalists?
that?
Okay.
That's it.
So someone working as a hospitalist tends to have an income a little bit higher than a doctor with the same training working in a traditional practice, at least for internal medicine and pediatrics. So an internal medicine trained doctor can work in an office or as a hospitalist. Usually the income is a little bit higher, maybe 5 to 10% higher as a hospitalist. It's not always true, but most often. Now, in other specialties, all of these usually make less working as a hospitalist. But one of the reasons they do it is they have much better hours. It is much less stressful. So this is complicated, and the remuneration is different for them. But for the medical hospitalists we're talking about, medicine and pediatrics, usually you make a little more. And in nearly every case, hospitalist groups in the U.S. get money from two sources. Let me back up and say physicians generally get money from insurance companies and a little bit of money paid directly by patients. So that's the system in the U.S. has been in place for 75 years, changing some now. But traditionally, insurance companies paid doctors. Hospitalists were really the first to be very different. Hospitalists are also paid by insurance companies, just like every other doctor. So I see a patient, I submit a bill to that patient's insurance company, and then that insurance company pays me. But those payments are not enough to make up my salary. So in nearly every hospitalist group in the U.S., the hospital where they work also pays money. And that was very unusual. Hospitals were not doing that for doctors. Even 15 years ago, hospitals paid almost nothing to doctors. They didn't need to. The doctors were paid by the insurance companies. But hospitalists started to change that. And it's now becoming quite common in other specialties that hospitals are paying money to support doctors in many specialties. So the hospital where I work now, 16 years ago when I went to that hospital, I was the only doctor that got any money from the hospital. And so it was, a very small amount of money. Today, my hospital where I work spends, I think, $26 million paying doctors across many different specialties. So from zero to $26 million in about 16 years. That's a big, big change for hospitals. So higher pay is not really a reason people choose to become a hospitalist, but the pay is a little better.
Well, first of all, thanks for your very insightful talk.
You're very welcome.
My question is, at the present moment, in your opinion, which would be the most relevant threat to the hospitalist movement in the United States, or concern?
The most relevant threat or thing that might...
or concern about the hospitalist movement in the United States?
Burnout. I would say the satisfaction of hospitalists themselves. Can they do this? Can a doctor be a hospitalist for 30 or 40 years of a whole career? There's many in the U.S. who say they don't think so, that being a hospitalist wears people out. They burn out and have difficulty, and that's the biggest concern. I'm convinced this model of practice is not going to go away. It's going to continue to grow. There is still a greater demand for hospitalists in the U.S. than there are enough doctors to fill the positions. If you look at the back of magazines, most of the advertisements are going to be for hospitalist positions. This specialty is going to continue to grow and be an important part of U.S. healthcare, I'm convinced. What we need to figure out, though, is how to make it most cost-effective, make it, arrange it so that it is a lifestyle and career that promotes, you know, it's something a hospitalist wants to do for their whole career. That's the biggest threat, in my opinion.
Do you see that the general medicine is growing with the hospitalists? The old doctor patient that knows much about the daily.
So is the practice of general medicine growing? I don't think so. So primary care medicine is really struggling in the United States. In many communities, it's very, very difficult to have enough primary care doctors. Many have a shortage. And almost anywhere you go in the United States, they would tell you, we'd love to have more primary care doctors, more office doctors. So partly because a lot of the people who in the past would have chosen to become office doctors, they've now chosen to become hospitalists instead. So but there's a shortage really in both places, though. The hospital and the outpatient setting has a shortage of doctors. Okay. Obrigado. I speak again in a little bit, and I'll talk about something a little different. Thank you.